Sexual masochism disorder represents one of the most complex and misunderstood conditions within the spectrum of paraphilic disorders. This psychological condition is characterized by recurrent and intense sexual arousal from the act of being humiliated, beaten, bound, or otherwise made to suffer as manifested by fantasies, urges, or behaviors that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The disorder extends far beyond casual experimentation or consensual adult activities, representing a pattern that fundamentally disrupts an individual's ability to maintain healthy relationships and psychological well-being. The diagnostic criteria for sexual masochism disorder require that these masochistic sexual fantasies, urges, or behaviors persist for at least 6 months and cause marked distress or impairment in the individual's life. Unlike consensual practices within the broader spectrum of human sexuality, this disorder involves compulsive elements that the individual cannot control, often leading to increasingly dangerous situations. The condition manifests through various behaviors including bondage, blindfolding, cutting, pinching, whipping, electrical shocks, or other forms of physical or psychological suffering that provide sexual gratification. Understanding the etiology of sexual masochism disorder requires examining multiple contributing factors. Psychological theories suggest that early childhood experiences, particularly those involving trauma, abuse, or disrupted attachment patterns, may contribute to the development of masochistic tendencies. Some individuals may have experienced early sexualization of pain or humiliation, creating neural pathways that associate suffering with pleasure. Additionally, certain personality traits such as low self-esteem, guilt, or feelings of unworthiness may predispose individuals to seek sexual experiences that involve degradation or pain as a form of psychological punishment or validation. Neurobiological research indicates that the brain's reward system may become dysregulated in individuals with sexual masochism disorder. The release of endorphins during painful experiences can create a powerful reinforcement cycle where the individual seeks increasingly intense stimulation to achieve the same level of satisfaction. This neurochemical process may explain why the condition often progresses in severity over time, with individuals requiring more extreme forms of pain or humiliation to achieve sexual arousal. The clinical presentation of sexual masochism disorder varies significantly among individuals. Some may engage in self-inflicted pain or seek partners who will inflict pain upon them. Others may focus on psychological humiliation or degradation rather than physical pain. The condition can manifest in relatively mild forms involving minor pain or restraint, or it may escalate to dangerous levels involving serious injury, suffocation, or life-threatening activities. This progression often occurs gradually, with individuals building tolerance to lower levels of stimulation and requiring increasingly intense experiences. Differential diagnosis is crucial when evaluating suspected cases of sexual masochism disorder. Clinicians must distinguish between consensual adult sexual practices and pathological behavior. The key differentiating factors include the level of distress or impairment caused by the behavior, the compulsive nature of the urges, and the inability to achieve sexual satisfaction through conventional means. Additionally, the presence of other mental health conditions such as depression, anxiety disorders, or personality disorders may complicate the diagnostic picture and require comprehensive assessment. Treatment approaches for sexual masochism disorder typically involve psychotherapy, with cognitive behavioral therapy being the most commonly utilized intervention. This therapeutic approach focuses on identifying triggers, developing coping strategies, and restructuring thought patterns that reinforce masochistic behaviors. Patients learn to recognize the cycle of arousal and compulsion while developing healthier expressions of sexuality. Group therapy may also be beneficial, providing individuals with peer support and reducing feelings of isolation and shame associated with the condition. Psychodynamic therapy can help individuals explore underlying psychological conflicts and early experiences that may have contributed to the development of masochistic tendencies. This approach examines unconscious motivations, defense mechanisms, and relationship patterns that perpetuate the disorder. Additionally, Trauma-focused therapies may be necessary for individuals whose masochistic behaviors stem from childhood abuse or other traumatic experiences. Pharmacological interventions may be considered in certain cases, particularly when the disorder co-occurs with other mental health conditions. Antidepressants, especially selective serotonin reuptake inhibitors, may help reduce compulsive sexual behaviors and address underlying mood disorders. Anti-androgen medications might be prescribed in severe cases to reduce sexual drive and provide individuals with greater control over their impulses. The prognosis for sexual masochism disorder varies depending on several factors, including the severity of symptoms, the presence of co-occurring mental health conditions, and the individual's motivation for treatment. Early intervention and comprehensive treatment approaches generally lead to better outcomes. However, the chronic nature of paraphilic disorders means that ongoing management and relapse prevention strategies are often necessary for long-term success. Prevention efforts focus primarily on addressing risk factors during childhood and adolescence. This includes protecting children from sexual abuse, providing appropriate sex education, and creating supportive environments where healthy sexuality can develop. Mental health professionals play a crucial role in identifying at-risk individuals and providing early intervention services before problematic patterns become entrenched. The societal understanding of sexual masochism disorder continues to evolve as research advances and stigma surrounding sexual disorders decreases. Education and awareness campaigns help distinguish between consensual adult practices and pathological conditions requiring clinical intervention. This distinction is essential for ensuring that individuals receive appropriate care while respecting the rights of consenting adults to engage in their chosen sexual practices without pathologization. Sexual masochism disorder represents a complex intersection of psychological, biological, and social factors that require comprehensive understanding and treatment approaches. Through continued research, clinical innovation, and compassionate care, individuals affected by this condition can achieve meaningful recovery and develop healthier expressions of their sexuality.